и координатором исследований по кардиологии в странах Совета экономической взаимопомощи, а также почетным членом и членом ряда зарубежных и международных научных медицинских обществ. Он был одним из участников разработки теоретических основ и системы восстановительного лечения и реабилитации при инфаркте миокарда. С 1966 года и до конца жизни работал в Институте кардиологии имени Мясникова, в последние годы возглавляя его. В 1974 году избран членом-корреспондентом, а в 1980 году академиком Академии медицинских наук СССР. Лечение сердечной недостаточности требует обширных знаний и высокой квалификации врача. Жизнь с сердечной недостаточностью также предъявляет серьезные требования к пациентам и их родственникам. Сложно разобраться в большом количестве препаратов, сложно следить за симптомами и правильно оценить их опасность. Наконец, сложно не сдаваться и не терять надежду. Помогите своим пациентам найти информационную поддержку и ответы на вопросы, которые у них возникают каждый день. Русскоязычная версия сайта Европейской ассоциации по сердечной недостаточности создана при участии общества специалистов по сердечной недостаточности. На страницах сайта пациенты и их близкие найдут ответы на самые разные вопросы. Причины и симптомы сердечной недостаточности. Как сердце и организм пытаются перестроить свою работу для адаптации к сердечной недостаточности. Чего ждать от вашего врача? Все о медикаментозной терапии сердечной недостаточности. И какие вопросы нужно не забыть задать на приеме у врача. Вам рекомендовано имплантировать устройство для контроля сердечного ритма. Что это значит и как изменится ваша жизнь? Что может сделать сам пациент, чтобы держать заболевание под контролем? Как самостоятельно измерить артериальное давление и частоту сердцебиения? И почему необходимо это делать регулярно? Питание, физическая активность, режим отдыха, другие аспекты образа жизни пациентов с сердечной недостаточностью. Эмоциональные проблемы и психологическая поддержка. Информация для членов семьи. Простые способы оказания помощи члену семьи, страдающему сердечной недостаточностью. Опасные симптомы, такие как боль в груди, одышка, нарастание отеков. Кроме того, на сайте представлена серия простых и увлекательных анимационных видео, объясняющих сердечную недостаточность и ее лечение, полезные материалы, которые можно распечатать с сайта, а также много другой полезной информации, которая поможет вашему пациенту лучше разбираться в своем состоянии и следовать вашим рекомендациям. Шхватсабая Игорь Константинович. Родился в Саратове в 1928 году в семье врачей. Игорь Константинович внес значительный вклад в изучение эпидемиологии ишемической болезни сердца и гипертонической болезни. Он был инициатором разработки научных основ и практических мер реабилитации, в частности психологической, больных с инфарктом миокарда. Шхватсабая сформулированы новые представления об основных патогенетических факторах гипертонической болезни в периоды ее становления и стабилизации. Им предложены новые подходы к выделению вариантов течения гипертонической болезни, а также разработано дифференцированное лечение больных с артериальной гипертензией. Шхватсабая являлся заместителем председателя Всесоюзного научного общества терапевтов, председателем Московского кардиологического общества, редактором раздела «Кардиология» Большой медицинской энциклопедии. Долгое время являлся экспертом ВОЗ и координатором исследований по кардиологии в странах Совета экономической взаимопомощи, а также почетным членом и членом ряда зарубежных и международных научных медицинских обществ. Он был одним из участников разработки теоретических основ и системы восстановительного лечения и реабилитации при инфаркте миокарда. С 1966 года и до конца жизни работал в Институте кардиологии имени Мясникова, в последние годы возглавляя его. В 1974 году избран членом-корреспондентом, а в 1980 году академиком Академии медицинских наук СССР. Лечение сердечной недостаточности требует обширных знаний и высокой квалификации врача. Жизнь с сердечной недостаточностью также предъявляет серьезные требования к пациентам и их родственникам. Сложно разобраться в большом количестве препаратов, Сложно следить за симптомами и правильно оценить их опасность. Наконец, сложно не сдаваться и не терять надежду. Помогите своим пациентам найти информационную поддержку и ответы на вопросы, которые у них возникают каждый день. Русскоязычная версия сайта Европейской ассоциации по сердечной недостаточности создана при участии общества специалистов по сердечной недостаточности. На страницах сайта пациенты и их близкие найдут ответы на самые разные вопросы. Причины и симптомы сердечной недостаточности. Как сердце и организм пытаются перестроить свою работу для адаптации к сердечной недостаточности. Чего ждать от вашего врача? Все о медикаментозной терапии сердечной недостаточности. И какие вопросы нужно не забыть задать на приеме у врача. Вам рекомендовано имплантировать устройство для контроля сердечного ритма. Что это значит и как изменится ваша жизнь? Что может сделать сам пациент, чтобы держать заболевание под контролем? Как самостоятельно измерить артериальное давление и частоту сердцебиения? И почему необходимо это делать регулярно? Питание, физическая активность, режим отдыха, другие аспекты образа жизни пациентов с сердечной недостаточностью. Эмоциональные проблемы и психологическая поддержка. Информация для членов семьи. Простые способы оказания помощи члену семьи, страдающему сердечной недостаточностью. Опасные симптомы, такие как боль в груди, одышка, нарастание отеков. Кроме того, на сайте представлена серия простых и увлекательных анимационных видео, объясняющих сердечную недостаточность и ее лечение, полезные материалы, которые можно распечатать с сайта, а также много другой полезной информации, которая поможет вашему пациенту лучше разбираться в своем состоянии и следовать вашим рекомендациям. Шхватсабая Игорь Константинович. Родился в Саратове в 1928 году в семье врачей. Игорь Константинович внес значительный вклад в изучение эпидемиологии ишемической болезни сердца и гипертонической болезни. Он был инициатором разработки научных основ и практических мер реабилитации, в частности психологической, больных с инфарктом миокарда. Шхватсабая сформулированы новые представления об основных патогенетических факторах гипертонической болезни в периоды ее становления и стабилизации. Им предложены новые подходы к выделению вариантов течения гипертонической болезни, а также разработано дифференцированное лечение больных с артериальной гипертензией. Шхватсабая являлся заместителем председателя Всесоюзного научного общества терапевтов, председателем Московского кардиологического общества, редактором раздела «Кардиология» Большой медицинской энциклопедии. Долгое время являлся экспертом ВОЗ и координатором исследований по кардиологии в странах Совета экономической взаимопомощи, а также почетным членом и членом ряда зарубежных и международных научных медицинских обществ. Он был одним из участников разработки теоретических основ и системы восстановительного лечения и реабилитации при инфаркте миокарда. С 1966 года и до конца жизни работал в Институте кардиологии имени Мясникова, в последние годы возглавляя его. В 1974 году избран членом-корреспондентом, а в 1980 году академиком Академии медицинских наук СССР. Лечение сердечной недостаточности требует обширных знаний и высокой квалификации врача. Жизнь с сердечной недостаточностью также предъявляет серьезные требования к пациентам и их родственникам. Сложно разобраться в большом количестве препаратов, сложно следить за симптомами и правильно оценить их опасность. Наконец, сложно не сдаваться и не терять надежду. Помогите своим пациентам найти информационную поддержку и ответы на вопросы, которые у них возникают каждый день. Русскоязычная версия сайта Европейской ассоциации по сердечной недостаточности создана при участии общества специалистов по сердечной недостаточности. На страницах сайта пациенты и их близкие найдут ответы на самые разные вопросы. Причины и симптомы сердечной недостаточности. Как сердце и организм пытаются перестроить свою работу для адаптации к сердечной недостаточности. Чего ждать от вашего врача? Все о медикаментозной терапии сердечной недостаточности. И какие вопросы нужно не забыть задать на приеме у врача. Вам рекомендовано имплантировать устройство для контроля сердечного ритма. Что это значит и как изменится ваша жизнь? Что может сделать сам пациент, чтобы держать заболевание под контролем? Как самостоятельно измерить артериальное давление и частоту сердцебиения? И почему необходимо это делать регулярно? Питание, физическая активность, режим отдыха, другие аспекты образа жизни пациентов с сердечной недостаточностью. Эмоциональные проблемы и психологическая поддержка. Информация для членов семьи. Простые способы оказания помощи члену семьи, страдающему сердечной недостаточностью. Опасные симптомы, такие как боль в груди, одышка, нарастание отеков. Кроме того, на сайте представлена серия простых и увлекательных анимационных видео, объясняющих сердечную недостаточность и ее лечение, полезные материалы, которые можно распечатать с сайта, а также много другой полезной информации, которая поможет вашему пациенту лучше разбираться в своем состоянии и следовать вашим рекомендациям. Шхватсабая Игорь Константинович. Родился в Саратове в 1928 году в семье врачей. Игорь Константинович внес значительный вклад в изучение эпидемиологии ишемической болезни сердца и гипертонической болезни. Он был инициатором разработки научных основ и практических мер реабилитации, в частности психологической, больных с инфарктом миокарда. Шхватсабая сформулированы новые представления об основных патогенетических факторах гипертонической болезни в периоды ее становления и стабилизации. Им предложены новые подходы к выделению вариантов течения гипертонической болезни, а также разработано дифференцированное лечение больных с артериальной гипертензией. Шхватсабая являлся заместителем председателя Всесоюзного научного общества терапевтов, председателем Московского кардиологического общества, редактором раздела «Кардиология» Большой медицинской энциклопедии. Долгое время являлся экспертом ВОЗ и координатором исследований по кардиологии в странах Совета экономической взаимопомощи, а также почетным членом и членом ряда зарубежных и международных научных медицинских обществ. Он был одним из участников разработки теоретических основ и системы восстановительного лечения и реабилитации при инфаркте миокарда. С 1966 года и до конца жизни работал в Институте кардиологии имени Мясникова, в последние годы возглавляя его. В 1974 году избран членом-корреспондентом, а в 1980 году академиком Академии медицинских наук СССР. Лечение сердечной недостаточности требует обширных знаний и высокой квалификации врача. Жизнь с сердечной недостаточностью также предъявляет серьезные требования к пациентам и их родственникам. Сложно разобраться в большом количестве препаратов, сложно следить за симптомами и правильно оценить их опасность. Наконец, сложно не сдаваться и не терять надежду. Помогите своим пациентам найти информационную поддержку и ответы на вопросы, которые у них возникают каждый день. Русскоязычная версия сайта Европейской ассоциации по сердечной недостаточности создана при участии общества специалистов по сердечной недостаточности. На страницах сайта пациенты и их близкие найдут ответы на самые разные вопросы. Причины и симптомы сердечной недостаточности. Как сердце и организм пытаются перестроить свою работу для адаптации к сердечной недостаточности. Чего ждать от вашего врача? Все о медикаментозной терапии сердечной недостаточности. И какие вопросы нужно не забыть задать на приеме у врача. Вам рекомендовано имплантировать устройство для контроля сердечного ритма. Что это значит и как изменится ваша жизнь? Что может сделать сам пациент, чтобы держать заболевание под контролем? Как самостоятельно измерить артериальное давление и частоту сердцебиения? И почему необходимо это делать регулярно? Питание, физическая активность, режим отдыха, другие аспекты образа жизни пациентов с сердечной недостаточностью. Эмоциональные проблемы и психологическая поддержка. Информация для членов семьи. Простые способы оказания помощи члену семьи, страдающему сердечной недостаточностью. Опасные симптомы, такие как боль в груди, одышка, нарастание отеков. Кроме того, на сайте представлена серия простых и увлекательных анимационных видео, объясняющих сердечную недостаточность и ее лечение, полезные материалы, которые можно распечатать с сайта, а также много другой полезной информации, которая поможет вашему пациенту лучше разбираться в своем состоянии и следовать вашим рекомендациям. Шхватсабая Игорь Константинович. Родился в Саратове в 1928 году в семье врачей. Игорь Константинович внес значительный вклад в изучение эпидемиологии ишемической болезни сердца и гипертонической болезни. Он был инициатором разработки научных основ и практических мер реабилитации, в частности психологической, больных с
Professor Anker,
инфарктом
can you hear
миокарда.
me? Professor Anker,
Шварцабая
can you hear me?
сформулированы новые представления об
Professor Anker,
основных патогенетических
please select
факторах
English channel.
гипертонической
Please
болезни
select
в
English
периоды ее
channel.
становления и стабилизации.
Please
Им
select
предложены
English
новые
channel.
подходы к выделению вариантов
Please
течения
select English
гипертонической
channel.
болезни, а также разработано дифференцированное лечение больных с
Please
артериальной
go to bottom
гипертензией.
panel of Zoom.
Шварцабая являлся заместителем председателя Всесоюзного научного общества терапевтов, председателем Московского кардиологического общества, редактором раздела «Кардиология» Большой медицинской энциклопедии. Долгое время являлся экспертом ВОЗ и координатором исследований по кардиологии в странах Совета экономической взаимопомощи, а также почетным членом и членом ряда зарубежных и международных научных медицинских обществ. Он был одним из участников разработки теоретических основ и системы восстановительного лечения и реабилитации при инфаркте миокарда. С 1966 года и до конца жизни работал в Институте.
Please select English channel. Please select English channel. Can you hear me, Professor Anker? Can you hear me, Professor Anker? Can you hear me? This is interpreter speaking. Please go to bottom panel of Zoom. Please select English channel. Please select English channel.
I selected the channel English, yes.
Can you hear me now?
Yes.
Thank you very much. This is interpreter speaking. So when they speak Russian, I will translate for you simultaneously. When you speak, I will go to Russian channel. Please don't be in a hurry because Russian is a bit longer like German. Thank you.
All right. When are we starting? Just
as soon as they start, I will start speaking. So yet I have silence in my earphones. No worries. So Professor Lopatin. Professor Lopatin is now in the screen. You can see him.
Yep.
And next to him should be Professor Mareev, but he's not yet there. So hopefully he will join us in a minute. So they will start in a minute, probably, in a minute or about.
Okay.
Thank you.
Thank you.
Good morning, distinguished colleagues. I am welcoming you at the symposia, which is carried out in the second of day 2 of Russian Congress of Heart Failure. We're extremely happy to all of you who are here physically today in the hall and all those who connected us virtually. Today we have hybrid conference, and this is a symposia which is supported by Boehringer Ingelheim. Well, today we are going to discuss two important topics: heart failure and atrial fibrillation. That's what we are going to talk about. Two conditions that guide the highest possible risks, those conditions that require continuous attention and action plan. My name is Yuri Lopatin. I'm the lead of cardiology chair and thoracic surgery in Volgograd State Medical University. Today, we are welcoming two great speakers, two stars, and this constellation will show us the most important issues for the management of patients with heart failure and with atrial fibrillation. Dear colleagues, today you have unique opportunity to ask questions to our speakers, to get extended answers, and it can be done by all those who are physically in the hall and also who connected virtually through the platform. So, distinguished colleagues, it's my greatest pleasure to give the floor to our first speaker, Professor Stefan Anker, who is the global expert, and actually he does not require any additional introduction, because lots of things are related to his name, multiple clinical trials that were then the basis of current guidelines for the management of patients with heart failure. Professor Anker is a past president of European Association of Heart Failure, and he's been doing quite a lot for the development of this direction in all the countries globally in the world. And today we are lucky because Professor Anker is with us. He will speak about heart failure and the new opportunities of treatment. Professor Anker, we are welcoming you. The microphone and the screen is yours. Please share your screen and start speaking up.
Thank you so much, everybody. Great pleasure to be with you. And if the moderator can allow me to share actually everything, then I can do so. In the meantime, I would like to say, Doppel Utro, and really, I'm very happy to be with you. Only like 4 or 5 weeks ago, I was in St. Petersburg, and I really enjoyed it. Euro, thank you so much for having had me there, together with Yevgeny Shliakto and others. And so I think here you see my first slide. And today I will have the chance to speak about new possible therapies of heart failure with reduced ejection fraction and the reasons why SGLT2 inhibition is now becoming one of the pillars of therapies there. Now, basically, when you talk about heart failure with reduced ejection fraction, let me start from the end. The end is we can treat heart failure with reduced ejection fraction very well. We now have a number of evidence-based established therapies that really are very much effective in improving the survival of patients, reducing hospitalizations, but also improving some of them at least, and I will show you this for empagliflozin and dapagliflozin in part, quality of life of patients. When you think of heart failure, there is of course a spectrum of heart failure, and I will review also what the new guidelines are saying. And you will find that they say relatively little about heart failure with preserved ejection fraction, where we don't have so much evidence, maybe with the exception now of some data from the Emperor Preserved trial. The history of SGLT2 inhibition developments in heart failure actually started in diabetes. And in the preclinical and clinical stage research, it was found that in diabetes, maybe also you have cardiorenal protection. And this was then evidenced in several studies with type 2 diabetes patients not suffering from heart failure when the treatment started. And so it was then shown that heart failure hospitalizations could be prevented, which led to the idea that maybe heart failure studies are also possible. And after the first were successful, it led to the idea that maybe also post-myocardial infarction studies are possible. The story of knowing about the success of SGLT2 inhibition in heart failure started with the DAPA-HF trial. And remember, there was a time when we had 30,000 people congresses. This was only 2 years ago. And this is a photo taken from the hotline presentation in Paris. The primary composite endpoint for dapagliflozin versus placebo in the DAPA-HF trial was 26% reduced. And interestingly, it worked. This treatment worked in patients with diabetes, but also in patients without diabetes. There was no significant interaction between the two. The treatment really had a strong impact on any kind of HFrEF patient. And we continued this work with the Emperor Reduced study and extended it also to the renal outcomes. And this is the trial I would like to focus here, first of all, about and tell you really more data about. So empagliflozin, 10 milligram once daily, was given to patients in a randomized way compared to placebo. All patients had an ejection fraction of 40% or less, and we included 3,730 patients. Patients were followed for 16 months. And these are the key endpoints we studied. The time to first event of cardiovascular death or heart failure hospitalization, first and recurrent heart failure hospitalization, and the slope of GFR change. So whether or not kidney function deteriorates. And the study included only symptomatic patients with and without diabetes. And in order to protect the event rates in the trial, there was also a nitric peptide level requirement, which was a little bit complicated, but basically it means that when your ejection fraction gets closer to 40, you were required to have somewhat higher levels here, 1,000 or 2,500, in order to have basically a residual risk in these patients that is high enough in order to focus mostly on these patients with lower ejection fraction and basically include patients that have a problem and need the therapy. I would like to emphasize that the exclusion criterion for GFR was one that said less than 20. That means up to 20 GFR, we included the patients. So this trial really has a very broad spectrum of patients with poor kidney function. When you look into the baseline characteristics of the EMPEROR-Reduced study, you can see the average age being 67 and about 1/4 being women in the trial. Half of them were diabetic. The ejection fraction on average was 27%, which is lower than was seen in the DAPA-HF trial with 31. The NT-BNP levels were about 1,900, which is really a sick population. The GFR was about 62. And if you look here, for instance, at the treatment at baseline for these patients, quite interestingly, also 20% of patients were already on an ARNI, 70% were on an MRA, and 95% had a beta blocker. So these were very well treated patients. Of course, an additional 70% had a RASI therapy beyond the ARNI. So cutting a long story short, this is the main result. The treatment worked. There was a 25% reduction in the composite endpoint of cardiovascular death and heart failure hospitalization. Highly significant result, as you can see here. There was an absolute risk reduction in this trial of more than 5%. So this is a meaningful and relevant difference. You can, with empagliflozin, make the lives of heart failure patients with reduced ejection fraction better. The results were driven by reductions in first hospitalization for heart failure, 31% less. And cardiovascular mortality contributed 8% to this. The hazard ratio crossed 1. So this wasn't in itself significant, but it all contributed to the big success of the primary endpoint. Interestingly, and this is something that is generally true for SGLT2 inhibitors and makes the use very useful, you get an early benefit. At day 12, the results were significant for the first time. And from day 34, the results were significant throughout the study. So after 1 month, you already get a significant benefit. And the hazard ratio already after 1 month was 0.67. And this is very much in line with what we see also now in new studies, for instance, also in preserved ejection fraction heart failure, very fast benefits. Let's look at the subgroups. First of all, what about diabetic and non-diabetic patients? There is a benefit that is very similar. You look here, 28, 22% benefit in diabetic and non-diabetic patients. The treatment works regardless of your diabetic status. Here you can see other subgroups pre-specified. All point estimates are to the left of the one line. So obesity, age, no big difference. Also men and women benefit from it. Here you see a second set of interactions, and particularly the previous heart failure hospitalization, previous use of MRAs or of neprilysin inhibitors, ARNIs, makes no difference to the benefit for the patients. Regardless of how well you already treat your patients, you get extra benefit from SGLT2 inhibition. So here then the results for heart failure hospitalizations. That is the total number of heart failure hospitalizations. Not only first hospitalizations are of concern for patients, but also recurrent hospitalizations. There is a 30% reduction for this endpoint. So not only the immediate risk, but also the long-term recurrent risk of hospitalizations for heart failure is reduced. And then come to an exciting aspect of this study, which is the kidney function improvement. There is a strong difference in how GFR changes over time in these patients. After 1.5 years, the absolute difference in GFR is more than 3 milliliters per minute. You can see here that there is an initial dip. It actually, in additional studies, we have shown that this is entirely normal to have this dip. It is no adverse consequence. And you can see very quickly over time, kidney function stays better in these patients and shows quite a difference at the end of the study. But also heart kidney outcomes are improved. So this is a sustained reduction of more than 40% in GFR or renal death or the development of dialysis need. So this is basically showing us that also hard outcomes of kidney events are reduced by 50%. Of course, the absolute number of these events is much less compared, for instance, to heart failure hospitalization events and cardiovascular death, but still also renal outcomes are reduced. And then we have other benefits beyond the event reductions. And it's important to note that also quality of life is improved when you're giving an SGLT2 inhibitor in heart failure patients. So this is, you might say, a holistic therapy. You improve events, you improve here quality of life as measured by the Kansas City Cardiomyopathy Questionnaire, but also you improve symptoms. So events, quality of life, and symptoms are improved. This is New York Heart Class improvement, showing a higher likelihood of improvement and a lower likelihood of having a deterioration in New York Heart Class. 40% more likelihood of being one class better, 30% less likely to be one class worse. So it is protecting the patient symptomatically in both directions. And of course, we want to understand a little bit more how all these benefits come about. And that's why we studied vital signs and biomarkers. And first of all, let's say these are officially anti-diabetic drugs, but the hemoglobin A1C change in the diabetic patients is very small. There's a strong increase in hematocrit. This is mostly due to the stimulation of erythropoietin production by SGLT2 inhibitors. It's known to happen. The diuretic effect may be there in the short term. In the long term, there isn't. And don't forget, there is a very small, relatively speaking, small anti-BNP change, only 13% reduced. In a diuretic, you would expect much more of this. Body weight didn't go down very much, only 0.8 kilogram, and systolic blood pressure is even changed less than 1 millimeter mercury for the systolic blood pressure. This is not how this treatment works. In honesty, we don't know exactly how it works. There's many ideas that is anti-inflammatory, protecting neurohormonal state and less free radical production, mimicking a starvation situation and thereby metabolically protecting the body. All of this is still under investigation. And yes, there's also, of course, cardiorenal protection and remodeling protection. But you can see it's almost like a multi-purpose drug that does quite many things pretty good. It's not a world record leader in any particular issue, but the fact it can do everything in the right direction, that's the useful thing about it. In terms of adverse events, you can see here the difference in numbers. Cardiac disorder problems, many more times more frequent in these patients than other side effects, but there is, for instance, no difference in symptomatic hypotension, no difference in hypoglycemia. Ketoacidosis didn't even happen. And there's a 1% difference in genital tract infections. There is some interesting subgroup results, and the diabetic and non-diabetic patients are such an example. And you can see here, for instance, the treatment, for instance, of diabetic and non-diabetic patients in our trial is very similar for the cardiovascular drugs, but very different for the anti-diabetic drugs. So patients without diabetes classification are really not on anti-diabetic medicines. Now, one interesting thing is to look from a pathophysiology standpoint, whether diabetes and pre-diabetes are the same or are different. So let's do this by looking at event rates. So here's the primary outcome in patients with and without diabetes. And I'm sure you're not surprised to see this big difference for diabetic and non-diabetic patients. But it was a surprise to us to see very clearly that pre-diabetic patients are very similar to patients without any glycemic disorder. And the diabetic patients, they have the higher event rates. So pre-diabetic patients are truly not diabetic patients. And when you look into the event rates and the Kaplan-Meier curves, you can see here that there is a benefit in both groups of patients. Of course, the event rates in absolute numbers are somewhat lower in those without diabetes. If you then look at the hemoglobin A1C over the whole spectrum, you can see that between 5.5 and 12, you get benefit throughout. There is basically no patient that doesn't get benefit from this by hemoglobin A1C standards. If you look into the hospitalizations, first and recurrent, you can see also very similar results. You can see in the mean here, in the middle here, always the interaction p-value. That means there is no significant difference between what we are seeing in both treatment groups with and without diabetes. The results are very similar, and they are also very similar for diabetic patients for the GFR change. You might say this is a higher number in patients with diabetes. There is no significant interaction. So overall, we could judge these results very similar. And interestingly, also for kidney function, we see that pre-diabetic patients are very similar to those without glycemic disorder, meaning that when we are saying diabetes is 50% in this trial, the pre-diabetic patients are truly non-diabetic patients. With and without neprilysin inhibition, you can see the results here, very similar results. So even on top of best therapy in heart failure, you still get the benefit. On top of neprilysin inhibition, you still get the benefit for the primary and the first secondary endpoint. This is good news. It really adds benefit to add empagliflozin. Here you can see the Kaplan-Meier curves, no significant difference between the two groups, and there is benefit in both subgroups. And this is true also for quality of life. You know that neprilysin inhibition does improve quality of life, and empagliflozin on top of neprilysin inhibition does improve quality of life. You can see it quite substantially for the Kansas City questionnaire. Now, many people have asked, what about the mortality result seen in EMPA reduced compared to DAPA-HF? And to this end, we have done a meta-analysis, and we would like to show you the results here to really document how similar these drugs are in this regard. You can see here EMPA reduced results, DAPA-HF results. You can see here the hazard ratios for those two drugs in between, and the joint effect is given here. It's a 14% reduction. And then important is this p-value here for heterogeneity. So are the results of the two trials different? Look at the overlapping hazard ratios. And that means basically within a little bit of variation of human life, which is variable, statistically speaking, you can basically say they are so much overlapping that there is, from a statistical standpoint, no difference at all between these results. The average mortality reduction with SGLT2 inhibitor in HFrEF is 14%. Now, when you look, for instance, at the combined endpoint of heart failure hospitalization and cardiovascular death, you can see it's almost identical, the results, 26% reduction for both trials together. And this is also true for looking at the patients with and without diabetes, showing no difference whatsoever. The benefit is there in patients with and without diabetes. It's also there in the different age groups. So it's important to say SGLT2 inhibition in HFrEF benefits also the oldest patients. There is a 23% reduction of the primary endpoint for both trials taken together. The benefit is clearly there regardless of age and also extends to the oldest patient. And when you look into the patients with GFR below 60 or above, of course, this is a vulnerable group of patients that we are taking care of. Then patients with a lower GFR equally benefit than patients with a higher GFR. No difference also for this. You can give SGLT2 inhibitors in HFrEF to every patient. Now, in terms of the renal outcomes, there was no significant result because the numbers of events were just too small in DAPA-HF. You can see here hazard ratios going beyond 1. But together with the EMPEROR reduced trial, you can see that the results are significant and there is a benefit that is very similar also for this endpoint across the two trials. And this is very helpful indeed. So let me summarize at this first level. In EMPEROR reduced, testing empagliflozin compared to placebo in heart failure patients with reduced ejection fraction, we have a strong results for the primary endpoint, CV death and heart failure hospitalization, for the first and the secondary second endpoint, and this basically means highly significant results throughout. Now, we can compare the results to what is seen in other trials, and you can see the number needed to treat here being very good, and EMPEROR reduced DAPA-HF paradigm are 19 to 21. There's very similar numbers, you might say, and it's good to know, but that the absolute risk reduction is also very good for these patients. If you then continue to ask yourself, what's the clinical impact of all these results? Well, first of all, the patients live better and live longer and live basically more out of the hospital. And the guidelines have recognized this. They have recognized for DAPA and empagliflozin that you can reduce in HFrEF the risk for heart failure hospitalization and death, and gave it a 1A indication. So this is really very helpful for our general practice, that there is now this kind of strong support from the guidelines. And this is in the context of the pillars of therapy being given here, all a class 1 recommendation, with the exception of ANI, all 1A indication. Now, this means we have a new algorithm of treatment. And when you look into the algorithm of treatment for HFrEF patients, you can see here the pillars of therapy, RASI therapy, beta blocker, MRA, SGLT2 inhibition with DAPA or empagliflozin, of course, diuretics to manage fluid. And then you assess the patient for their ejection fraction and for their QRS width and the sinus rhythm status. And you consider, if it's really necessary, ICD therapy or CRT therapy in these patients with HFrEF. So that's the start of the algorithm. But if you then consider more in the guidelines, and we shortly want to review what is in the guidelines, we should also look into the diagnostic algorithm. And the first statement I would like to make is that nitric peptides and echocardiography are key investigations beyond the assessment of risk factors, signs and symptoms, and the ECG for patients are key assessments for patients to then classify them according to their symptom status as having heart failure and signs, of course, and then classify them for having HFrEF versus HFmrEF and HFpEF. Now, of course, whoops, if you, I don't know, let me restart my PowerPoint. Wait a second. Maybe it didn't like the guideline slide, but it's still a good one. Give me 1 second. So basically in the diagnostic process for patients with HFrEF, we want to establish the diagnosis using nitric peptides, but also using then the approach. 1 second, now I can share my slides again. Give me 1 moment. Okay.
This is a slide with diagnostic tests tests in Russian.
Yeah, 1 second. Yes, but share. Now you should have it. All right. So basically, we want to investigate the patients when they are presenting to you with ECG and echo and anti-BNP and routine kind of blood tests. In the blood test, we have, of course, blood count, urea for the kidney function and the overall hydration state, electrolyte, thyroid function, but also iron status is mentioned. All of this is receiving a class 1 recommendation. And when you look into the nitric peptides, there is anti-BNP, BNP, but also mid-region pro-ANP. There's 3 nitric peptides that you can use. Now, interesting is then also the classification of HFmrEF and HFpEF. And HFmrEF in our guidelines, there is a new statement that a slight reclassification that HFrEF goes up to 40% and HFmrEF is really the group in between. HFrEF 40% or less, HFpEF 50% and higher, and in between is HFmrEF. And now when you want to assess the patients with the HFpEF, you need to find evidence for objective evidence for cardiac structural or functional abnormalities. And you might say, what exactly is this? Well, in the guidelines provide a list of what can serve to prove that there is structural abnormalities, and you can use the left ventricular mass index or the relative wall thickness, the left atrium volume index, E to E prime, of course, NT-BNP and BNP. You can use all of this to make sure that truly there is a cardiac problem. Ejection fraction is 50% and higher. Signs and symptoms of heart failure are present, and then you can diagnose HFpEF. HFpEF basically has limited amounts of therapies recommended, and these are based on subgroup results on meta-analysis. So for patients up to 49, you might say 50%, you can, of course, consider giving RASI therapies, MRAs, and ARNIs. For the patients above and equal 50%, there we have very limited recommendations. At the time of the guideline writing, Emperor Preserved wasn't known yet, so treatment of comorbidities is still recommended there. First of all, and then, of course, management of fluid status with diuretics. So this is now the full guideline kind of cycle. You have here the fundamental management, the pillars of therapy, RASI, beta blocker, MRA, SGLT2 inhibition. Then you check for the diuretic need. You check what I said before about ICD and CRT. And then you have this phenotyping approach. Is there atrial fibrillation? Is there coronary artery disease? Iron deficiency? Atrial fibrillation with sinus rhythm, or alternatively sinus rhythm and a high heart rate? What about mitral regurg, aortic stenosis? So there is different options for different patients. It's phenotyping, you might say, comorbidity directed. Interesting is also really now a strong emphasis on iron supplementation in order to improve quality of life and exercise capacity, but also events can be reduced because the AFFIRM-HF trial has shown this. So the guidelines are now taking a very holistic approach. Let me conclude, and I'm looking forward to our discussion. We now have very strong evidence that heart failure with reduced ejection fraction, besides using RASI, besides beta blocker and MRA use, also should be treated with SGLT2 inhibitors. All of this is a class 1 recommendation. These are the pillars of therapy, the foundational therapies. We can make a difference to these patients. It's most important that we start doing this. We have evidence that we are not doing enough. In this big registry, we looked into patients that didn't have a contraindication for one of these important medicines. And still, you can see big proportions of patients not receiving a medicine despite absence of a contraindication. And I would like all of us together to consider giving these medicines because particularly SGLT2 inhibitors don't have any electrolyte abnormality. It couldn't be easier to give these medicines from a safety aspect, but also from very practical aspects. Look at SGLT2 inhibition. It's once daily, it's single dose, no titration. 10 milligram once daily is all you need to remember. It couldn't be easier to give an SGLT2 inhibitor. So let's together make SGLT2 inhibitors part really of the standard of therapy in these patients. And I hope we can now explore this further in the discussion. Thank you so much for your attention, and thank you, and talk to you now also in the discussion.
Thank you very much, Professor Anker, for fantastic presentation, for this opportunity to see the new data that will guide the management of heart failure patients in the near future. And definitely your presentation, your slides would stimulate multiple questions that we are going to discuss together with you. Well, in our country, in Russia, we have 2 SGLT2 inhibitors registered, DAPA and EMPA. And moreover, our professional community already started working with the next version, updated version on heart failure management in Russia for the next year. So we have a question. We have 2 SGLT2 inhibitors. We need to select probably between one and the other. If we use particular phrases that we see in Caroline Lamb or Javetta Butler publication, so there are several factors how to select the treatment, starting from the evidence-based data, starting from the particular statements in the particular state, and the financial aspect. Well, guided by your experience, this selection between 2 SGLT2 inhibitors, similarities and differences between the trials that you've shown brilliantly, but still, what arguments would you provide for the selection, for example, of empagliflozin, arguments in favor of EMPA? Thank you.
Thank you so much. Interesting question. Well, there is, of course, relatively small differences. Interestingly, both drugs have 10 milligram once daily, and both drugs have very successful results in heart failure with reduced ejection fraction. But if you want to really look into the differences, well, one difference that is obvious is that the GFR for inclusion of patients was lower in the EMPEROR reduced study than in the DAPA-HF trial. It was 20 versus 25 for the lower limit of inclusion. Is this really a major difference? Well, you have, of course, some patients with a reduced kidney function, and it gives you maybe more certainty that we included patients at the lower end there as well. In terms of the outcome results, you have very similar overall results. The meta-analysis has shown this. if you look into the results with these drugs outside of the heart failure space, in, for instance, type 2 diabetes, you have the DECLARE study with dapagliflozin, you have the Renal Outcomes trial with empagliflozin. The mortality result was much better in EMPA-REG than in DECLARE. Actually, DECLARE had only a 2% reduction in cardiovascular mortality, and there was a 38% reduction of mortality with empagliflozin. Of course, you've seen the results in the heart failure trials. There is a nominal difference between the two trials, but the meta-analysis suggests it's the same. You know, honestly, very little difference in terms of the data. It now becomes a question maybe of the practicalities of using. How easy is it available in your area? And maybe the economics of using. Of course, I can't really comment on prices and such things. I just don't know the prices, particularly not in Russia.
Thank you very much. Thank you very much, Professor. Dear colleagues, any questions, you are welcome. And we have some questions from the hall, and currently Professor Lopatin is carrying the microphone to the audience. Well, thank you very much for a fantastic presentation. I have a question to ask. Well, this group of treatments, SGLT2 inhibitors, they don't increase ejection fraction. They don't increase because, and follow-up period was 1 year. But what would happen next? Let's say if the drug is not improving the left ventricular function, what are the perspectives in the future? Well, and well, I'm sorry for this, what warranties, what guarantees we could give to the patients for their future, patients with heart failure? Thank you.
Well, thank you so much. I mean, the trial was 1.5 years on median duration. The range was about half a year to about 3 years. And we didn't see over time any variation in the results. Of course, when you consider then the patients beyond 1.5 years, that's less many patients, but still there are quite a number of patients. So I would say the results are between half a year and 3 years duration. So that's the first statement. The second statement, we have never seen a medicine in heart failure yet where you don't, where when you have benefits in the first 2 years, that you don't have longer term benefits. And so this should give us reassurance from this more like historical perspective. And really we are seeing reductions in heart failure hospitalizations a lot, 30%, reductions in cardiovascular mortality, 10 to 15%. But don't forget, when you reduce heart failure hospitalization, you reduce another risk factor for future mortality. So there is every reason to think that this is even beyond 3 years, you have benefits in the much longer term. From the diabetes studies, we know benefits go 5 to 7 years, which were the duration of the trials there. You know, guarantees, there's no such thing as a guarantee to live forever in human life, I'm afraid. I'm afraid life is a 100% deadly disease, some people say. So I don't know, this is difficult. But let me also say, there is a number of studies showing that SGLT2 inhibitors in the context of diabetes, in the context really of having severe risk coronary artery disease and risk factors, is positively impacting on remodeling of patients. So the ejection fraction may not be the best criterion for assessment here, but remodeling is positively impacted.
Thank you very much, Professor Anker. This is fantastic response, very important response, especially if we discuss real implementation of the results of the studies in the clinical practice. This is exactly the task. This is exactly the question we are asking to medical community in the whole world. So it's very important to understand future perspectives. Professor Mareev, this is your question. Stefan, good morning. I would like to ask a question that is most frequently asked in Russia, most frequent questions. So 4 classes, 4 major classes, that's great. And you cannot give them in one day. It's great to give them, but you cannot, as you clearly understand, you cannot give 4 pills immediately overnight. So there are 3 options to resolve the problem, and they're actively discussed. First, to give all 4, like it's written in European guidelines, then to start with ARNI in beta blockers, and then add on the rest of the classes, like American colleagues offered. And the third option, which Milton Packer and John McMurray offered, to start from SGLT2 inhibitor and beta blocker, and only then add ARNI or ACE inhibitor and MRAs. But keeping in mind that, well, financially, maybe you not always are able to give 4 treatments, let's say, overnight. So I would like to get your position. What would be the best algorithm of, let's say, order of administration? Yes, we all understand that you need to give all 4, but in which order? Thank you.
Well, let me make 2 or 3 basic statements. One, the case that somebody has no treatment at all of the 4 treatments is a very rare case. People will have hypertension, and because of this, they already have an ACE inhibitor or a beta blocker. People will have coronary artery disease and already have a beta blocker, maybe also a RASi inhibitor because of this. People will already have had diabetes, and maybe they already had an SGLT2 inhibitor. So I would say the situation that somebody has no treatment of these 4 is rare. I'm coming back to this in a second, but now let's take the most common situation is, I think, that you have probably 2 treatments at a suboptimal dose, or maybe only 1 treatment, but 0 is rare. And if you then add the other therapies to the already existing therapy, the first fundamental statement is it is better to be on 3 or 4 therapies than on being on 1 or 2 in the maximum dose. So first add the new therapies before you maximize the dose of the existing therapies. That's my first statement. My second statement is we don't need to discuss in most places which of the 4 therapies is the most expensive one. They have similar effectiveness. So if resources are limited, I think beta blockers, I think SGLT2 inhibitors are the easiest and cost-effective drugs. And the MRAs, they are typically causing the most problem when up titrating. So maybe the MRAs need a special focus and could be the number 4. They shouldn't be forgotten, but they need special focus because of the potassium problems you very often have with the MRAs. The second problem you very often see in this context of starting the therapy is then, of course, hypotension. This is certainly something you see quite often with RASi inhibitors, with ARNIs, possibly also with MRAs. So you need to focus on this. And now I make my second statement. If you are really a patient with no treatment on board, it doesn't matter in which order you give it. Some people argue you should be on 4 therapies in 2 days and 4 days. I think 4 weeks is enough. It doesn't matter which order you give it. In a diabetic patient, I would put maybe an SGLT2 inhibitor amongst the first 2. In a non-diabetic patient, I would put it amongst the second 2. I would probably put an MRA always in the second 2. A beta blocker low dose, RASi low dose starting can be very fast started. Is that, what do you think, both of you? Is this some reasonable approach? I mean, there is no right and wrong answer for this.
Stefan, I'm still insisting. So patient come, enalapril, eplerenone, bisoprolol, not optimal. What would you do first? SGLT2 inhibitor
That's
or
an
ARNI?
easy case. That's an easy case. Give SGLT2 inhibitor. Just make sure the fourth therapy is on board. I assume that this patient with these 3 therapies, suboptimal, does not have current kidney dysfunction, does not have ketoacidosis, and the patient can tolerate another drug if it doesn't impact on blood pressure. I would give, in this particular case, I would give an SGLT2 inhibitor. In our practice, we would give empagliflozin 10 milligram once daily. That's it.
Thank you very much, Professor Anker. Well, and this discussion that we initiated pushes us to the idea that such discussion should deserve more attention. Well, and I think we are entering the period where we identify patients' profile starts playing a big role. And I can refer you to the document of the European Association of Heart Failure, the recent document, which is actually devoted to the patient's profile, so-called patient's profiling. And I think that's one of the right ways to go for the selection of the treatment. Professor Ranker, once again, we dramatically, deeply enjoyed your presentation, your questions and your answers. We're always happy to see you in Russian Federation, and not only virtually, but also face-to-face, as it happened a few weeks ago. Thank you very much. Have a good day and hope seeing you again. Bye-bye.
Thank you. Bye-bye. And hopefully in Volgograd next year, right?
Well, be sure you already got my invitation. It's already here. It's already here. Bye-bye.
Thank you. Bye-bye. Добрый день.